Let's go ahead and get started. Welcome everyone to our April installment of Ask the Doctor. I'm Shelley Kurian with SkyPass Foundation, and we are here to discuss motor fluctuations and dyskinesia with a very special guest tonight, Dr. Cynthia Comella. Dr. Comella is a professor emeritus of neurological sciences at Rush University and a movement disorders neurologist with expertise in the evaluation and treatment of dystonia. She completed her fellowship in movement disorders at Rush, and prior to retiring her clinical practice a year ago, she was an active clinician for 33 years. In addition to her many other accomplishments, Dr. Comella is an active researcher and has published original research primarily focused on dystonia and Parkinson's disease. Dr. Comella, thank you so much for being here. I know our attendees are excited to hear from you tonight. Moderating tonight's discussion is Dr. Shilpa Chitnis, SkyPass Foundation board member and professor of neurology and movement disorder specialist at UT Southwestern. Welcome, Dr. Chitnis. Thank you again for being here as always. If you are watching this live and you have questions throughout the presentation, feel free to put those in the chat box or the QA box at the bottom of your screen. And we'll try our best to answer as many of those as we can. We also got some questions with registration that we will address at the end of the discussion. And with that, Shilpa, take it away.
Yeah, hey, thanks so much. And, hey, Cindy, how's it going? Dr. Kamala is one of my most favorite people on this earth. In addition to, she really is like my big mentor that I really consider one of my big mentors. But over time, your mentors can become your friends. And so I also consider her to be a very good friend and soulmate. When in trouble, I basically on Sunday afternoon call her, and I have never been disappointed. So, I got to say a big plug for mentors. And Cindy is not just my mentor, I think she's everybody's mentor and has just been a great force in the movement disorder society. And I can probably talk for 24 hours about Cindy's accomplishments, but Cindy is too humble and modest. So we will just basically talk about what our topic is today. Um, so Cindy, okay, so let's start with really the basics. Like, can you tell our audience what are motor fluctuations? Like, what do you mean when people are talking about motor fluctuations? What does that mean?
Well, first, let me start out by thanking you, Dr. Chitnis, who has also been my mentor and my friend for many, many years. I think the Dallas area is really fortunate to have such an expert in movement disorders right there for you. So, take advantage of the resources that are available to you. And I want to thank you, Shilpa, and also the SkyPass Foundation for having me. So let's get into the meat of it. What are motor fluctuations? People use the term in different ways, but motor fluctuations really refer to that time when after you start levodopa and you get a benefit from it, at first it looks like, it's just smooth going all day, no ups, no downs. And then typically after maybe 3 to 5 years, some people earlier, some people much later, you begin to notice that the effect wears off. So you have this good effect, and then you start feeling your symptoms coming back at the end before you take your next dose of medication. And it can happen not only with the motor part, meaning it may be recurrent tremor or stiffness or gait difficulties, that's the motor part, but it can also happen as a non-motor phenomena. So at the end of dose, you feel anxious or depressed, or even pain has been described. And this is because the benefit of the levodopa is not lasting the interval between doses. Now, motor fluctuations could get even more complicated. I mean, what I describe is called wearing off motor fluctuations. So that's when the effect wears off. But there can also be in the morning, for example, early morning akinesia, we call it. You wake up, you feel stiff, you don't feel like you're mobile and dynamic until after you take your first dose of medication. There can also be the phenomena of the sudden on-off. And that means you're doing pretty well, but all of a sudden, boom, either motor or non-motor symptoms recurs kind of unexpectedly during the day. And usually in some ways it's predictable, because some people notice this in particular after a meal, for example, or if they're really excited about something, or if they have to cross the street and there's a lot of stress, and they'll feel this sort of sudden turning off phenomena. And those are really the major types of motor fluctuations. I don't want to overwhelm you with every single type that's been described, but those are the major types of motor fluctuations that we see in a clinical setting. What do you think, Shilpa?
Yes, I think this is wonderful, Cindy. And, this is even more than very good detail. I think it's so important for people to understand that there is, so much more to motor fluctuations. That's excellent. And so my second question, just as a segue to, is, then what are dyskinesias? And you probably mentioned some, but,
Yeah, no, I didn't mention, because I usually think of motor complications as both motor fluctuations and dyskinesia.
Yeah, that's right.
It may be my own way of thinking about it. But dyskinesias, again, you don't start out that way. But as time goes on, you'll notice that maybe a half an hour, 45 minutes after you take a dose, you begin to have little movements. And it may actually be the person that's around you that says, "Why are you jittery?" You don't feel jittery. These can become more intense as time goes on. Typically, they occur at the peak of the dose. So when levodopa is having its best effect is when they will start. They can be this wiggly. Sometimes they're a more fixed posture, like a cramping in the foot that can occur. And they can happen typically at the peak of the dose. Sometimes they can happen as medication kicks in, or as the medication is leaving its effect. So it's waning its effect. So those are called diphasic dyskinesia. And Parkinson's is not the same disorder in everybody. So everybody has their own way of feeling dyskinesias, and they may even have their own pattern. That's why sometimes we'll say, well, can you keep a diary so we can keep track of when this is occurring? And then we're able to better identify it.
Yes, absolutely. And again, you mentioned this, but let me just ask, and what stage in the disease do these, both the motor fluctuations and dyskinesias normally manifest? And I know they could be different for young onset versus, older onset.
Right. Typically, it's about 3 to 5 years is when you'll begin to notice them. But again, as I said before, some people, you notice it a little earlier. Some people, they don't notice it for more years. So whenever we give these estimates, there's people that fall on this part of the estimate and these people that fall on that part. So if you start getting them and you say, oh my God, I'm not supposed to have them for 3 years, don't worry about it. Everybody has their own pattern. You just make sure you tell your doctor, because there's so much we can do about them now.
Yeah, absolutely. And not everybody may have painful or really disabling dyskinesias, right? I mean, in today's day and age, with us knowing how to manage these things, right, that I don't really see any painful or disabling dyskinesias. But you may have seen some, in the early part of your career when we didn't have a lot of these therapies, I guess.
Yeah, I started a long time ago. When I started, we had levodopa, we had pergolide and bromocriptine. I don't mean to date myself, but I am. That means I'm old.
You're evergreen and ever young. If I were to get in a walking competition with you, you would outdo me. So don't worry.
But again, I agree with Shilpa. There is so much that we can do that one does not need to suffer with disabling dyskinesia. If you just have a little twitch here and there, it's like, if it doesn't bother you, do you really want to start another medication? Do you really want to do anything about it? Knowing that if it gets worse, hey, then we'll start a medication.
Yeah, absolutely. And most of the times, you can laugh at this. It's really you ask the patient, is this bothering you? Then why are you, wanting a medication? Well, so, well, my wife doesn't like my headache.
That's right. Sometimes it's not you. It's
So I have
somebody
to think
around you
you
that
for what your wife likes or dislikes.
and sometimes it's just a matter of understanding what it is. So it may be that the person that's looking at you doesn't understand what's happening. And so that's why you really need to have a discussion with whoever it is that's around you that's noticing this, again, with your neurologist.
Yeah, absolutely. And and maybe you can just tell us a little brief about, why do these happen? Like, what's the, pathophysiology behind motor fluctuations and dyskinesias?
Well, we've said nobody really knows
Correct.
is the bottom line. But we've said that there is a reduced ability to store dopamine. And when you take a tablet of levodopa, in fact, it gets stored and released. And as the neurons drop out, there's less ability to be able to store it to smooth out the day. Dyskinesias, it's probably a receptor problem. Now, which receptor has always been the interesting question. Right now, D3 D3 has been popular for a while. So we know it's going to be a receptor, a supersensitivity, perhaps of the D2 receptors, of some of the other receptors, but an interaction of receptors that causes the dyskinesias, which are reversible. It's not like everything is gone to pot. They are, again, with medication or with drug adjustment. They are treatable. I shouldn't say reversible, but treatable.
And so you as an expert, at what point do you start? Because, sometimes the patients may not be able to volunteer the history that the medicine's wearing off, or they're starting to twitch. Like, how do you approach these? Like, how do you, ask patients about this?
Well, usually what I say, because they'll know what it's like to have like good time, when they start the medication, moving better, driving better, walking better, or whatever the symptom that's most troublesome. So usually what I say is, how do you feel before you take your next dose? Do you feel like you're still at your optimal? And that's usually when I'll pick up that someone is waning. And then it's, how much does it bother you? How much does it disable you? Do you want to, because there's all sorts of ways we can approach this. Dyskinesias, typically I start with the observer because they're the ones that notice it first. So you'll have patients that may have a lot of dyskinesia, but it doesn't bother them. It doesn't get in their way. So I'll start with the caregiver first. Treatment is really a discussion, though. When to treat these is not, well, I see it, I should treat it. It's not an emergency. It's a discussion. Because some people say, well, really, I'm not, it bothers me a little, but not a lot. And so why would you readjust everything for that? So it's a very practical approach that I think one has to take.
Yeah, absolutely. And so is there, like a new patient that's starting out with the disease, is there anything that they can do to delay the onset of wearing off and dyskinesias in them? Like, is there anything that you would approach?
Well, that's almost a trick question. So it used to be said that if you use longer acting, and I think this is in part true, longer acting medications, that you can likely delay the onset. In fact, with the dopamine agonists, and here, of course, we're talking about pramipexole, ropinirole, or rotigotine. They're very long acting, and they were compared to levodopa. And in fact, they did delay the onset of motor complications. The problem is they didn't work as well. And the second problem has been that they have more side effects than levodopa. So sometimes we do not opt to go that route. But we do try to keep the dose. We don't just throw a lot of levodopa at someone. We try to keep the dose as low as possible because that's another strategy. Don't push the dose. And we saw this in Stan Fahn's study, the L-DOPA study.
Yeah, absolutely. But of course, patients are always worried about, starting levodopa. I mean, when I started, we definitely had the option of using dopamine agonists at that point because they weren't so, such villains. We didn't know so much about them, right? So you basically, in fact, it was interesting that with my friends at various universities who are all assistant professors, we had this competition as to for how long you could keep a person on a MAO-B inhibitor and a dopamine agonist, very functional, and delay the introduction of levodopa, right? And so it's interesting how paradigm shifts, 20 years later now, I'm like, let's go with levodopa, right? That's
Well, the dopamine sparing strategies were really at one time very popular.
yeah.
But the problem with them is, first of all, these dopamine sparing strategies, they don't have sometimes enough benefit. And certainly dopamine agonists, the side effect profile, you have to keep an eye on because they do have more in the way of side effects than levodopa. So I've been a levodopa user, but when I started, that was really what we used. But there is no evidence, let me put it this way, there is no evidence that levodopa is bad for you. None. Okay?
Thank you.
Good drug.
Thank you so much. I cannot tell you how many hours are gone in discussions trying to convince patients that levodopa is not the villain. It's not Darth Vader. You can embrace it, and that's what you need. So coming from you, I think this is going to help me in the future. I'm going to give you 10% of my salary.
All right.
Okay, so now you have a diagnosis. You basically diagnose somebody that's wearing off. We'll talk about wearing off first and go to dyskinesia later. What is the first thing that you do? Like you think somebody is now having wearing off. Like, where do you start? And we'll talk a little bit about medications as we talk. But what's your first strategy?
Well, the goal is to optimize therapy and not to make Parkinson's a burden by giving people so many medications they can't even keep track of them. So my first step typically is to shorten the interval between levodopa doses. So if you're taking it 3 times a day, so let's say 7, noon, and 5, we may go to a 7, 11, 3, and 7. And a lot of times that strategy is very effective and you don't have to do anything else. You don't have to add a drug. Now, will the motor fluctuations recur? Likely they will. And then you start talking about adding on medications because you can't have somebody taking pills every 2 hours. That again is a burden. And our job is to keep that burden reduced, to keep it as low as possible with the medications and the Parkinson's.
Yeah, absolutely. And you probably lived in the era of liquid levodopa where you told people to put ascorbic acid. And go ahead, I'll let you tell that story.
Now, we wrote the recipe. I mean, honest to God, it used to be horrendous. So for liquid levodopa, I'll just briefly talk about it because it's not really too relevant now. But it would be, you would measure it out in a liquid form, and a patient would be expected to take a sip every hour. Now, just talk about burdensome. So some people would do it and they liked it maybe for, a couple of weeks. And it's like, geez, I got to walk around with levodopa all the time, drinking it out of a thermos. So we don't do that so much anymore. A lot of better things to do now.
Yeah, absolutely. Okay, so perhaps we can, start talking about some medications for addressing wearing off, and maybe we can start with like one medication at a time, and you can give me your expert opinion. So, what do you think about rytari?
Well, rytari is a combination of a long-acting levodopa and a short-acting levodopa. So you get the on with the short-acting, and then you get more a sustained benefit from the long-acting contained in the same pill. I like rytari especially for early fluctuations and people who are not having a lot of difficulties with dyskinesia. So for early fluctuations, rytari is nice. It's expensive. So a lot of times there's the battle of, can I get it for you or can I not? The pre-auths and whatnot in the special pharmacies, et cetera. If you get it, people really do like it. Now, typically involves taking more than one pill, because of its dosage, the way it's dosed, you may end up taking 2 or 3 pills at the same time at various points in the day. But it's worth it if you have to take them less frequently. So you don't always have to be like, okay, is it time yet? That kind of thing.
Yeah. Oh, that is so Cindy. That is it time yet? The way you said it is so you. Like, I could have seen it on anybody and known that it was you. but what do you think about dyskinesias with rytari? Because we're giving them obviously a conversion, so we're multiplying it by the rytari conversion factor, and they're getting a higher, so the magnitude, they're getting a higher dose. And so do you worry about dyskinesias being a problem?
Oh, I do worry about it.
Yeah.
But the bioavailability isn't the same, so it's not like you're taking that much of an instant release levodopa. So what I do is I just titrate.
Yeah.
Patients are your best guide. The people I took care of, I relied on them to tell me how things were working, because I only saw them for the 20-minute return visit, and they lived with it 24/7. So I counted a lot on their input. Keep this in mind when you're talking to your doctor, in order to have the appropriate response. But rytari in the right person is a great drug. Rytari in the wrong person, i.e. they get too much dyskinesia or they get erratic responses, you have to move on.
Yeah, and I also tell patients that you really cannot afford to be constipated when you are taking rytari. You really need to clean out the bowels pretty well. I see people that don't do well just because of the constipation. Okay, very well. And so moving on, to just another medication that we used to use in the past a lot, which was COMT inhibitors. So now we have 3 of them. So we basically have Compt, and we have talcopone, tasmar, that we don't use that much. But then now we have obviously opicapone. That's the new kid on the block. And so what's your philosophy on Compt inhibitors at this stage with having perspective that we have rytari?
I think that Compt inhibitors are useful. Entacapone, Comptan, is a very nice drug, except that you have to take it with every dose of medication. So you're taking a lot of pills, and that tends to be expensive and rather cumbersome. But in some people, they just love it. They think it's a great drug. Others, it's like, are you giving me placebo? Is this sugar pills? It just doesn't work.
Yeah.
I think opicapone is kind of, that's a once daily. So opicapone is really, I haven't had enough clinical experience using it. When I left my clinical practice, we were just starting to use it. But in fact, the clinical trial data is really quite promising. Now, if you use it, remember, you only use these Compt inhibitors as an adjunct, as an add-on to levodopa. They are not going to work if you use them by themselves or as an add-on to a dopamine agonist.
Yeah.
So it's only if you're on levodopa that they're even relevant. Talcopone, because of the potential for hepatotoxicity, even though it's probably the best of the Compt inhibitors, but we don't use it.
Yeah, no, absolutely. I mean, I remember my early experience with Tasmar. I mean, because it was only 3 times a day as opposed to with every other dose, people really liked it. I mean, people were very sad when it went off the market because, it did give them, almost like 3 hours of on time as opposed to, 1 to 1.5 hours with the others. So you're right. But, and I've just started to use opicapone, so we'll find out. But the Europeans seem to really like it. Like the Europeans swear by it. They've had it for a few years before us. They seem to swear by it. So we'll see.
The clinical data is really good.
Yeah.
But still, these Compt inhibitors, they give you maybe an hour of extra, not to say that an hour isn't important.
Yeah.
But approximately an hour, maybe up to an hour and a half. Keep in mind, that means that some people may have 3 hours and some people may have less, because we're always talking about these, these peaks, and we're not talking about all the people that are included in the tails of the peaks.
Yeah. No, absolutely. And then staying on board with levodopa formulations. What is your experience, or what's your, review of the clinical data on Ambrisia?
Well, Ambrisia is inhalational levodopa, and it's meant to be an on-demand therapy. So the place you typically use Ambrisia is when you have one of these wearing offs that's unexpected, or that is expected sometimes, and you have a way to, so it's an inhaler, you inhale the levodopa, you bypass all, because levodopa has to get all the way to the small intestine if you take it by a pill. That's a long trip. So if you inhale it, it gets into the bloodstream much more quickly and into the brain. So you can see benefit. Usually you'll start to see benefit 15 to 20 minutes after you do it, and then it'll maximize at about 30 minutes. Sometimes less, but the data is approximately a half an hour for the optimal, the maximal. But that doesn't mean you're not moving better as it's kicking in. So you don't really have to worry about the optimal. Ambrisia is an inhaler of a powder. Probably the most frequent side effect that I heard was that cough. Despite the fact that it does not cause, at least any of the studies, none of them have demonstrated any bad effects on the lungs. But you can imagine when you inhale a powder, you're going to cough. And if you happen to get it on your clothes, it's going to stain brown. So that's another one. And the last one is sometimes people find these inhalers, because you have to put 2 containers into the inhaler for a single dose. They find it a bit cumbersome. So some people really like it, and some people either find that it's not sufficient for them, or they find that it's kind of too much work. Here they are, they're off, and now they have to get those. So it's often best if you have someone with you who knows how to use it.
Yeah, absolutely. And I always wondered that why they did not make they made a formulation without carbidopa, I guess because it was supposed to be taken. I mean, you're waiting for your levodopa to kick in, but I wondered why they could not make one with carbidopa and it was levodopa alone, right? So you couldn't take it by yourself if you were not on levodopa, carbidopa, as your, so like you said, it's a rescue therapy and not something that you can just take every hour or something.
Yeah, you're limited to 5 doses a day. And again, you have to walk around with that inhaler. So if you forget your inhaler, or if you're like me who can't find their keys or always leaves them upstairs, sometimes that can be a problem. So you have to keep in mind sort of the convenience of it. But some people do really well on it. Again, I bet you in all the patients I took care of with Parkinson's, especially when we got all these drugs, I don't think I had anybody that was on exactly the same regimen. You match the regimen to the need.
Yeah, no, absolutely. That's a really good point. And then last one, the LCIG, the levodopa carbidopa intestinal gel pump, also known as popularly as Duopa.
Mm-hmm.
And what is your experience and belief on that?
Again, I think it works. It does actually smooth out the day, because you're pumping the levodopa gel right to the area in the intestine where it's absorbed. So it doesn't have to go down that long pathway and sometimes just get stuck in the stomach because there is slowed stomach emptying associated with Parkinson's. So you deliver it right where it needs to be. People do well with it insofar as less fluctuation, and actually less dyskinesia as well in many. Again, there's always an issue. The issue is you have to carry around a pump. So they have them now in these nice, they look like little travel packs. They look a lot better than they did before. And you have to have a tube placed into your stomach. That used to be a big deal. There was a lot of complications. There still are, but they've modified the tube such that there's much fewer problems with it.
Yeah, absolutely. I mean, heard stories of tubes kinking and infections and things like that. But then, then I'm the biggest proponent of inserting an electrode in the brain. So I should not say. I think,
Well, I'll tell you, most patients, when it comes right down to it, end up, not European patients. European patients use it all the time. But Americans, we like DBS better. And I have to say, I kind of feel the same way because it's not so cumbersome. Because again, the idea is for everybody to forget about Parkinson's and not constantly have the weight on their shoulders or the pump on their shoulder. So, but some people like it, and that's why it's a very individualized kind of thing.
Yeah, and then perhaps with people who have some cognitive impairment, maybe duopa may still be a possibility for them when DBS may not be a possibility yet.
Absolutely. In specific patients, you would go to that. But then you have to make sure there is a care provider that can handle. I mean, if you're cognitively impaired and you're trying to figure out, this whole pump thing. So you have, in that instance, you really need to have a friend.
Yeah. No, absolutely. And let me see what else we have. So then we have Kinmobi, of course, apomorphine. Maybe you can talk about apomorphine, subcutaneous as well as Kinmobi on top of that, which is the sublingual apomorphine.
Yeah, so apomorphine, it's too bad it's not a continuous infusion. But apomorphine is not levodopa, but it's a dopamine agonist that acts very similarly and very quickly. So if you give that into the skin, you can get a very rapid absorption and a very rapid turn on, so to speak. So you feel the effect very quickly. So when you inject it into the skin, you'll feel the effects. It's usually within 10 minutes. Now the effect will wear off typically within the hour. So it's kind of the perfect way. It's like somebody with diabetes injecting insulin. I mean, it's the same kind of procedure, if you will. And then you have the and then the regular medications can kick in. The problem again is, syringe, you have measured amounts of apomorphine. Sometimes it causes nausea, sometimes it causes hypotension, so a lowering of the blood pressure. So these are always things that you're concerned about when you prescribe it. And after you prescribe it, then people have to be, we used to bring people in and titrate them to the optimal dose, the dose that would work the best for them, and then send them home. And people used it a lot. The sublingual apomorphine, that's the latest thing. With that, you have to make sure, first of all, that you drink some water before and that you put the sublingual tablet under your tongue. It's a wafer, actually, under your tongue. And you're supposed to hold it there for 3 minutes. You're not supposed to swallow it. It doesn't work that way. So it gets absorbed under your tongue and then gets into the bloodstream. And this is another way. It's not quite as fast as being able to use a needle and inject it. But it's another way to turn on When I say turn on, I mean go from off state to a better on state or more mobile on state, to turn on quickly. And we view this as an on-demand therapy, meaning it's not something that you're going to be using regularly, but it's something that you can use in those circumstances like, oh my gosh, I'm eating dinner and I'm off and I need to go home. So it's something you can use in that type of situation.
Yeah, no, absolutely. Um, and then, I remember the last one I was going to ask you about is Nurians or Stradifylin. And the one thing I can make a comment about is like, I was a fellow in 2002 and we were doing the trials there. And, and it got approved only, 2019, like 2020. So, it took, obviously the clinical trial data was not very appealing to the FDA for it to not get an approval. What are your thoughts on that?
Well, that class of drugs in general has had a rocky road. The A2A receptor antagonists have had a rocky road. Istradefylline did make it and demonstrated, I can't remember exactly, but 40 to 50 minutes of additional on time. I have not used it as much in clinical practice. So Shilpa, I'd really be interested more in your experience with it.
Yeah, and I've also just started using it right through the pandemic. We don't have, people are not coming in, we're not giving samples, but the couple of people that I've used on it were happy. They were okay with it. So we'll have to have them come back, and we're just not seeing patients as regularly as you would see on follow-ups because of the pandemic. But a couple of people, I have like maybe 3 or 4 people, and they liked it. They said it helped them enough that they did not want additional help from me at this point. So we'll find out.
Yeah, I
maybe-
think clinical experience. So we come out with clinical trial results, and that's how drugs get approved. In a clinical trial, you have your optimal inclusion criteria, your optimal patient, and you try, usually it's the drug versus placebo. And then when you get into a more clinical setting, it's not that everybody isn't optimal, it's just that they don't fit the inclusion criteria for that study, so they may react differently.
Yeah.
And again, always keep in mind, there is that, they take means, but there's both sides of that slope. So people who do better and people that do worse. For any given therapy, anything we talk about, when we start talking means, you have to keep in mind you could either do better or worse than the mean.
Yeah, absolutely. And so and I just want to say that Amantadine, Gocovri just got approved just yesterday or a couple of days ago for more on time. So it was approved basically for management of dyskinesias, but it just got approved also to provide more on time. So thoughts about Gocovri and maybe Osmolex also?
Well, I really, Amantadine is a really amazing drug. We found that it helped Parkinson's by accident. And then we found it helped dyskinesias. We almost stopped using it. And then it helped dyskinesias. It wasn't quite by accident, but we were surprised. So those extra abnormal movements can be dampened by just regular old Amantadine.
Yep.
And then Gocovri came out, which is a long-acting Amantadine. And you take it once, you take it at night. And it dampens both the dyskinesias and increases the time, smooths out your day. So I liked that drug. The problem with, I think, that drug is that it is Amantadine. So it carries with it all the side effects. So if you have, for example, kidney failure or significantly impaired kidney function, one has to be careful with the drug because that's how it leaves the body. That's how it's metabolized. But I really have to say that I thought with the reduced dyskinesia, which was its first approval, and the increase on time, that it's worth a try in many patients.
Yeah, absolutely. I think the clinical data says up to 4 hours of on time. I remember reading the prescription information, and I have to go and look at the clinical trial again now after the approval. But that would be great if it was up to 4 hours of on time.
Yeah, I didn't think it was quite that much. I think it's, yeah, but it's significantly better than some of the other alternatives we have insofar as increasing on time. And the beauty of it is it doesn't enhance levodopa. It actually treats the dyskinesias that are caused by levodopa. So it's kind of a cool drug, except you always have to keep your eye on the side of swollen ankles. You know, it's sometimes people feel foggy with it, hallucinations, but that can happen with any of the medications. Not an emergency, you just won't be able to continue on that particular medicine.
And constipation, certainly imagine.
Constipation is for everything.
Yeah, absolutely. Yeah, so it's kind of like a two for the price of one. I guess you could get on time without dyskinesias. So that's a good thing.
If it works for you, that's the way it's supposed to work.
Yeah.
More on time, less dyskinesia.
So my question to you, Cindy, is they have tried so many medications. You know, dyskinesia is just like freezing of gait. It's like a holy grail. Why are they? Why we've known about Parkinson dyskinesias forever and ever. None of the drugs for dyskinesias in clinical trials have really worked. And what do you think about that?
Well, I mean, I think Amantadine has worked.
Yeah.
And GoCovery has.
Yeah.
Why don't we have more?
Yeah.
I mean, people are looking at zonisamide. So we'll likely have more, but I think part of the problem is not quite understanding the underlying pathophysiology. And that's, and then we have DBS. So when someone has dyskinesias that we can't seem to control, and the motor fluctuations with off periods coming on during the day, usually I would call up my colleague, Dr. Chitness, and say, I think I have one for you.
Yeah,
if I lived in Dallas.
If you live in Dallas, and now we have, I'm going to put a plug in for Dr. Nader Paratian, who's the new chair of neurosurgery, who's a movement disorder functional neurosurgeon that just moved on April 1 from UCLA. And I'm actually taking him out to dinner tomorrow, and we're going to talk about, the program, and it's going to be really a lot of fun. But if I can say, yes. So I have lots and lots of experience with DBS, and really, done the right way, in the right kind of patient, with the right surgeon implanting it at the right point, you can certainly get good on time, and and get management of dyskinesias. And depending on the target, like if your target is the globus pallidus internal segment, or GPI, then you get a direct anti dyskinetic benefit, and you don't necessarily have to reduce medications. But if you are going to do bilateral subthalamic nucleus, or STN, then you get the relief of dyskinesias by going up on the stimulation and going down on meds. But definitely that's we've had great experience with treating dyskinesias.
And she's an expert.
Thank you. And let's see. I think a couple more. So what do you think about Neuroderm, the levodopa patch clamp? You think there's
it's not been approved. And I don't think that the final results are available yet. So Neuroderm, what it does is you can't do a levodopa patch because levodopa doesn't go through the skin. So what they've done is they have like these they're like little, I'll call them little needles, but they're really tiny pinpricks. And it enables the Neuroderm, the levodopa in the patch, to get under the skin and into the circulation. I think if it works, although there's a limit on how much levodopa they can put on these patches, but if it works, I think it will be another tool. I don't think anything is a cure is a miracle, but another tool. And you need as many tools as you can get, especially because Parkinson's is a complex disorder. It's not an easy disorder. It's something where you have to finesse, you have to think about it. You can't just do the same thing for everybody.
Yeah, absolutely. And I think, Shali, with that, that's a excellent amount of information. And one of the beauty of talking to Cindy that I have always found so amazing is just her clarity of thought. I mean, she makes the most complex of information so simple to understand for everybody. And that's a beauty of being a real expert, and it's a real honor to just know you, Cindy, and have
Oh, thanks.
your expertise today and every day.
Thank
So
you so much, Dr. Comella. We did have some questions that came in. Shilpa, if you could check your private
yeah,
chat as well.
I'm looking at them as we speak. And then Susie Baxter says, dyskinesia from too much medication. And I think you alluded to
Well,
that. Yeah.
well, I think you have to define what too much medication is. Sometimes you can't improve, you can't get your sufficient symptom relief without dyskinesia. That's why we're developing drugs to treat dyskinesia. So dyskinesia is not typically, especially with a movement disorder specialist, it's not an over medication, but it has to be dealt with. Okay, and if it's disabling.
Yeah. And so Julia says, I have anxiety attacks and depression when the medication is wearing off. I only just realized this. I see a psychiatrist for medication to treat these. How can I differentiate and communicate this to him?
Well, I think again, if you feel that this happens at the end of dose, and it's not something that is pervasive, because you can be depressed or you can be anxious without wearing off. But if you feel as the medication is wearing off, this sense of anxiety, this sense of depression, and you really need to talk to your doctor about, my medicine is not lasting long enough, because as soon as it's time to take, right before it's time to take the next dose, I've heard people say, I feel like I'm smothering. So there's a variety of ways people have of describing these non-motor, and these can be addressed by using a lot of the medications we just talked about to extend the time of benefit from any given drug.
Yes. And I think this question was answered. Have you had any experience with Nurians? And we just talked about it briefly. Um, so does it, the question was, does Kinmobi lower blood pressure like apomorphine?
It can, yes, it definitely can. And you're not supposed to use certain types of, so one of the side effects of apomorphine, it used to be used as a way to make people throw up, actually, as an emetic agent. And so at first you wanted to be on an antiemetic, and it's suggested in the label. I don't know if it's necessary, but you can't be on certain of the antiemetics because the two of them together can really lower blood pressure. So it's something that when I start patients on that, I say, well, if you start to feel lightheaded after you take this, first of all, put your feet up and lie down so you stop feeling lightheaded. And let me know, because it may mean that we'll have to either adjust the dose, or perhaps it's not the medication for you. But yes, it can cause hypotension, not as much as the subcutaneous.
Yeah. Cindy, somebody has a comment. Susie Baxter wants to say, Dr. Comella took care of my dad in Chicago. So lucky to have had her for his care. So
I thank you for saying that. My patients were what kept me running for so many years. So thank you.
And then Sharon Roberts, who's one of my patients, had a comment. She said, Dr. Children's gave me 3 months on pramipexole. When I came to her, I was taking it for about 2 to 3 years and didn't want to give it up. So glad she insisted. So I slowly weaned her off it. And Sharon is a fantastic patient. She is your, role model. Sharon is how every patient should be. I want to be like Sharon when I grow up. Let me see. Apomorphine, I'm allergic to morphine. would I be able to use it? I don't need it, just a question.
Yeah, you can use it.
Yeah.
Yeah, it's not the same thing.
Yeah. I've had PD since 2013. I take 4 tablets of carbidopa, levodopa each day. I actually don't feel the effect of wearing it off. However, I do feel very sleepy, tired, and balance gate problems. Would Nourians help me?
No, probably not. I think this is a question you would want to ask your doctor. Again, motor fluctuations occur at varying durations in different people. But gait disorders, balance problems, sometimes don't respond well, as well to levodopa. So other medications, now some have suggested selegiline would help, but Nourians, I don't see that helping. At least I haven't seen any evidence that it helps with balance.
What is the general timing of PD progression for total immobility so we caregivers can plan financially and for physical accommodations? We've heard over and over when you know a person with PD, you only know one, but there are some general conditions and timings for PD information on the typical stages and time periods that really help us all to prepare. We are on stage 3 to 4 now with Walker, mostly with assistance.
You know, I get asked this question in clinic all the time. You know, where am I going to go from here? And it is really a very tough question to be able to answer, because progression, you know, it's the Janus effect. Where you've been, where you are, where you're going to be. So progression a lot of times is dependent on where you've been. So some people can have Parkinson's. I still talk to her. I don't take care of her, but I have a woman who's had it for 25 years, and she's still exercise. She has problems, but 25 years worth of Parkinson's and functional. I have had other patients where after 15 years, there's been a lot of difficulty. They're really completely disabled. So I'm not trying to be evasive by any means, but I think to give timelines that are general, because remember those means, is almost it's almost not fair. If it's a slowly progressive, and the best person to talk to about this, because they'll know the patient with Parkinson, the person with Parkinson's the best, is the doctor. The neurologist that's taking care of you is the one that ought to give you information about prognosis. I mean, I'm a firm believer that everybody should have a living will. I have one already. And, you know, the medical the attorney, I think that everybody should be, because you never know what's going to happen. But with Parkinson's, I think it's really tough to give a prognosis that's meaningful for an individual when you don't even know that individual. Yeah, that's the best I can do.
Yeah,
Shilpa, anything?
Yeah, so since rytari has a quick acting and long acting levodopa, is it more forgiving when meals are eaten?
That has not really been my experience, that it's more forgiving. Now, if you have some benefit from the last dose before the meal, that can be forgiving. But it's still absorbed. It still has to get through the GI tract and get to the right spot in order to be absorbed. So if you have a meal and you take rytari, it's still going to have the same problem, getting to where it needs to go. And that's when these rescue therapies come up, you know, inhalational levodopa, apomorphine, and the like.
And I think those were my questions. I had a comment to make, Cindy. You said that, you know, you have a living will. And as an adjunct to that, I said, you're not going anywhere. You will live forever. And by forever, I also mean in the hearts and minds of all that have benefited from your kindness, expertise, and care.
Well, you know, Shilpa, right back at you. It's an honor for me to be able to participate in this kind of activity. I can't thank you enough for having me. It's fun to talk to, and I wish we could do it in person, is all I can say.
Thank
Oh,
you so
I just have
much,
one more
Dr.
question.
Comella. Go ahead, Dr. Chitnis.
Is it protein or iron that interferes with L-DOPA? That was the
Protein.
protein. Yeah.
Wonderful. I think we got all of our questions answered. And with that, we will wrap it up for tonight. Thank you again so much, Dr. Comella. It was so great to meet you.
Thank you.
And thank you, Dr. Chitnis.
Have a good night.
Good
Bye,
night.
guys. Thank you.
Bye-bye.